And I'm really excited to introduce my colleague and friend, Nazem Akoum. Nazem was born in Saida, which is the 6th largest city in Lebanon, if you don't know. And I looked up a little bit about it just to learn where he was from. And so some things to know. It was named for Sidon, which is was the great grandson of Noah from the Old Testament. And it was an important city in the Phoenician Empire for making glass and purple dyes. And should you decide to visit with Nazem as your guide, of course, you can see the Sea Castle, which was built in the 13th century by the Crusaders. Or there's the Soap Museum, which traces the history of soap in the region, including how to make olive oil soaps. I don't know, Nazem, if you've ever gone or not. But Dr. Akoum himself, he got his BS and MD from the American University of Beirut. And he came to the US for residency at Indiana University, and then cardiology and EP fellowships at the University of Utah. And he was on faculty at Utah for several years before we recruited him to UW to be our director of our AFib program in 2015. And he's now the EP fellowship program director. He's our interim section chief for EP, and he pretty much does everything for the EP section right now. He's received a number of awards. He was 3rd place in the Northwestern Cardiovascular Young Investigators Forum. He presented a late-breaking clinical trial at HRS last year, and he's had a lot of roles with ACC, AHA, ERA, HRS. He has 78 publications on AFib, stroke, ablation, atrial fibrosis, including a recent editorial in JAMA. And I'm really excited to hear his discussion today about translational applications of atrial fibrosis and electrophysiology. So thank you, Dr. Akoum.
Thank you very much for the very kind introduction. I honestly expected something soccer related, but you keep surprising me, Dr. Bretkin. All right, I've started a screen share. Can you all see my screen?
We can. We see the, not the slideshow version of it though.
Okay, here we go.
Yep, great.
Okay, thank you again for the kind introduction. Thank you for the invitation, my colleagues on the Grand Rounds Committee, and also for everyone to joining early this morning, our faculty, our fellows, our staff, and also our guests. I don't have any disclosures that are relevant to this talk. Here's what I'm going to try to cover today. I want to start with a clinical scenario, basically a 2021 AFib patient, and how the management goes these days, especially with the results of the recent clinical trials. And then I'm going to link that to atrial fibrosis and show you how that's relevant and how we make our decisions today. So we're going to talk about fibrosis and AFib risk factors. We're going to talk about the role of fibrosis in rhythm management outcomes. I'm going to share with you the results of the DECAAF-2 trial. And I'm also going to tell you about some of the research that we are doing in that space. The second part of the talk will focus on stroke risk. And I'm going to talk about the role of fibrosis there and stroke risk in patients with AF and in patients with embolic stroke of undetermined source. And also finish by telling you about the ongoing work that we're doing and future directions in that space. All right, so let's talk about our patient. It's a 67-year-old man with high blood pressure who presented after his Apple Watch alerted him for a fast heart rate. The next time it happened, he actually put his finger on the dial and actually recorded an ECG, and the read suggested atrial fibrillation. So he went to his physician's office and then got a hospital-issued monitor, which again confirmed a correlation between his symptoms, his watch, and the presence of atrial fibrillation. And on a patch monitor for 7 days, he actually had 12% AF burden. Together with that, he reported symptoms of palpitations, shortness of breath, and decreased energy. He was started on oral anticoagulation and was referred to the AFib clinic. Now, what do the guidelines tell us? And it's always it's always good to start there, even though guidelines tend to lag behind the clinical trials and the recent evidence. And this is especially true for ACC and AHA and HRS guidelines, and the European guidelines are actually more recent and more updated. So what the European guidelines tell us is that, first of all, we have to confirm the diagnosis. So we have to confirm that we have atrial fibrillation. But soon after that step, after confirming atrial fib, we actually have to go through the 4 S's, the 4S scheme, to characterize that AFib. So what does characterizing AFib mean? We have to characterize the stroke risk. So in the case of our patient, using the CHADS-2-VASc score, he has 2 risk factors, which are high blood pressure and age greater than 65. We also have to characterize the severity of his symptoms. So there are different ways to study that and quantify that, mostly centered about how limiting the symptoms are, how much do they interfere in their day-to-day activity. And the European Heart Rhythm Association has a score that's easy to use and that we've actually adopted here in our clinic. The third S in the 4S scheme is characterize the severity of the AF burden. So how much AF is this person having? Is it paroxysmal? Is it persistent? Are they in it all the time? Do they go in and out? How much time do they spend in it? And then the 4th S, which ties into what I'm going to talk about later in the talk, is characterizing the substrate severity. So understanding what is leading to atrial fibrillation, what neighborhood does this atrial fibrillation live in, and what company does it keep? So what are the comorbidities? What's the underlying atrial substrate as far as atrial enlargement, atrial fibrosis, which we'll talk about later. After characterizing the AFib, with this 4S scheme, then you move on to treating the whole spectrum of AF disease, which starts with anticoagulation to avoid stroke, improving the symptoms with rate and rhythm control strategies, and also addressing cardiovascular comorbidities and other risk factors for atrial fibrillation. Now, a few trials have been published over the past few years, and this is especially true since the last time I spoke to you, which was probably 5 or 6 years ago. And the common theme to me from all of these trials is that of early treatment or early intervention, early rhythm control for our AF patients. So the biggest of these trials is the EAST AFNet 4 trial, which was published last year and was presented at the European Society of Cardiology Congress. And the way this trial was designed was to enroll patients with less than a year from their initial AF diagnosis. And these patients were randomized to an initial rhythm control strategy versus conventional treatment, which largely consisted of rate control. They all received appropriate anticoagulation therapy. And as you can see from the breakdown of what that early rhythm control was in the intervention arm, there was a lot of antiarrhythmic drug use, and these are the choices that those patients were given. A small percentage of these patients underwent ablation initially, so about 8%. And then during follow-up at 2 years, there was a shuffling a little bit of what antiarrhythmics they were on, and also a shift towards more ablation during follow-up. Now, this trial was powered to look at hard outcomes. So the primary endpoint was cardiovascular mortality, stroke, heart failure, and ACS hospitalizations. And it showed that in the early intervention arm, there was actually a reduction of this combined endpoint. So early rhythm intervention for these patients seemed to result in a reduction in cardiovascular mortality, stroke, or heart failure, ACS hospitalizations. And then I want to contrast that to a trial that has impacted our management of AFib for the past 20 years or so, which is the AFFIRM trial. And in the AFFIRM trial, which was similarly sized, maybe a little bit bigger actually, patients who were randomized to rhythm versus rate control, where the primary outcome was mortality from any cause, the intervention arm, rhythm control for AFFIRM, actually did not show a survival benefit So we can talk about why this happens and why East AFNet had a different outcome. But the common theme that I will come back to is this early intervention strategy, which probably played a big role. Another couple of trials that also are along the same theme of early intervention were published in the same issue of the New England Journal earlier this year, where patients also with a relatively newly diagnosed atrial fibrillation were randomized to either receive catheter ablation or antiarrhythmic drug therapy. And in both trials, the early AF trial, which is on your left-hand side, and the Stop AF First trial, there was a significant improvement in AF rhythm control with early intervention with ablation in that population. And the median time since the diagnosis to receiving treatment or randomization was 1 year for early AF and 1.3 years for a mean time for Stop AF First. Now, let's try to understand this in the context of the AF substrate and what leads to the development of atrial fibrillation in the first place. And from what we know at this current time about the pathophysiology of atrial fibrillation, there are several components to what creates the atrial fibrillation substrate. Part of this is electrical. There are certain changes that happen at the level of the tissue of the atrium, mostly electrophysiological remodeling that involves ion channel expression, that leads to changes in the action potential of atrial myocytes and to triggered activity through early and delayed after depolarizations. But there's also a substantial role for an atrial substrate that includes a large component of atrial fibrosis that provides a structural substrate for sustenance of this arrhythmia, both in a functional as well as in an anatomical reentry mechanism and fibrillatory conduction, and what we currently understand as what's needed to sustain the arrhythmia. Now, the presence of fibrosis has been studied extensively and proven time and again. On the histology slides that you see on the left side of the screen, these are trichrome stains from atrial samples obtained from patients at autopsy. And the patients with a long history of atrial fibrillation have been shown here to have substantially more structural remodeling, more collagen, more fatty infiltration into the atrial tissue as compared to patients in panel C, where they did not have a history of atrial fibrillation prior to dying, and they had significantly less atrial fibrosis compared to their AFib counterparts. This is also true when samples are obtained from atria of patients undergoing cardiac surgery, where patients with a history of atrial fibrillation, either in the presence of structural heart disease, in this case mitral valve disease, or in the absence of the known cardiovascular problems associated with AFib, the so-called lone AFib, both of those groups have significantly higher collagen content in their atrial tissue compared to patients undergoing surgery but without a history of atrial fibrillation. Now, the European Heart Rhythm Association has also gone a step further and characterized what's known as a atrial cardiomyopathy. And this is continuing to be an area of active research. Some of those areas we're intimately involved with. But the mechanism of development of fibrosis and atrial cardiomyopathy is obviously not the same in every person. But the most common mechanism involves a lot of myofibroblasts and fibroblast activations and deposition of a lot of collagen within that atrial tissue. Some of the atrial substrate can also be genetic or primary cardiomyocyte related with more of an electrical substrate rather than a structural substrate. Now, for us, when we were managing patients with atrial fibrillation who come to our attention, what we'd like to know is what we're dealing with on the surface, which is episodes of atrial fibrillation, paroxysmal or persistent atrial fibrillation. What we would like to know is what's happening underneath. Where are where are those changes at in that particular patient, and what stage of that substrate development is that patient in. So when they come to us after their second or third cardioversion, are they further along in that substrate development, or are we still dealing with an early substrate, which would be more ideal for that patient? And this is where non-invasive imaging comes into the picture. And this is the work that we've been involved in for the past 12 years or so, where we've leveraged the ability of cardiac MRI with late gadolinium enhancement to actually study these fibrotic changes that happen at the level of the tissue. The way this works, as you all know, takes advantage of the kinetics of gadolinium as an extracellular contrast agent, where fibrotic areas with a larger extracellular space will be hyper-enhanced on this type of imaging compared to healthier tissue. What we do with the high-resolution cardiac MR images that we obtain is a lot of image processing that allows us to study the atrial wall within each of the slices that are obtained from the mitral valve annulus all the way up to the bifurcation of the pulmonary artery or the dome of the left atrium. And we characterize within that atrial wall which areas are hyper-enhanced and which areas are not. And we do that on every slice and obtain this three-dimensional model that shows the extent and also the distribution of atrial fibrosis within that atrial wall. Now, we have also shown that when biopsies are obtained from patients with AFib going on for cardiac surgery, when the biopsy is obtained from those hyper-enhanced areas, there's a correlation with a higher collagen content when we look at the tissue from these areas under the microscope. Now, how does this correlate with the known associations between AFib and clinical risk factors? In this study, we examined the association of fibrosis characterized by cardiac MRI with age and sex. And we all know that the prevalence of atrial fibrillation increases with age. We show here that when these AFib patients are grouped by decades of life, we show a trend towards higher atrial fibrosis in both men and women. We also show that women actually in each of these decades have higher degrees of fibrosis compared to men, except for those older than 80 years, where there may be some survival bias or selection bias in that group. These are the possible explanations for why that trend is reversed in that greater than 80-year age group. We also have shown that the fibrotic signal that we're seeing on MRI tends to be progressive. So in a cohort of patients who have had this MRI to evaluate their atrial fibrosis, with a time between two MRI scans of about 2 years, there was significant progression. I see here I show you here an extreme example of patient at point A where the fibrosis was 6.1% and at point B was up to 31%. The progression usually isn't that fast over 2 years, but this is an extreme example just to illustrate the point. Also, we show that, and these patients didn't have AFib at the onset of their, at the first MRI, but some of them had it after this follow-up period. And we show that those patients with who had actually shown AFib in follow-up had an even more significant progression of their atrial fibrosis compared to those who stayed in sinus rhythm. And this takes us to the other modifiable risk factors, or some of them are not modifiable, but the other risk factors that are associated with atrial fibrillation as a clinical entity. And this has received a lot of attention, mostly through the work of Melissa Middledorp and Prash Sanders and the University of Adelaide, who is one of our collaborators. And probably the one risk factor that has received the most attention in this scheme is obesity. And Prash and his group have studied this extensively, both in humans and also in animal models. And they studied the impact of obesity, weight loss, and weight fluctuation on atrial fibrillation burden and also response to treatment. So in the legacy study, where patients who had atrial fibrillation and were obese to begin with were put in an aggressive weight loss program, some of them succeeded in losing the weight and keeping it off more than 5% of their starting weight, and some of them didn't. But what these Kaplan-Meier curves showed is that the patients who actually succeeded in losing weight and keeping that weight off and avoided weight fluctuation have seen a reduction in the burden of atrial fibrillation that they have had. And this is both with ablation and without ablation. So the graphs on the panel B here are results of AF-free survival after intervention for rhythm, mostly with ablation. And then the graphs on the left-hand side are without rhythm interventions. Now, how does this play out? How does obesity actually impact atrial fibrillation, and how does this tie back to left atrial fibrosis and that substrate that we're talking about today? There are several hypothesized mechanisms, and these are ongoing studies that are trying to elucidate this mechanism and understand how these factors play out. So there's a prominent role that we think local epicardial adipose tissue plays. So it's not just overall body obesity, but there may be a role for epicardial adipose tissue, so the fat that's near the left atrium. There's some local hormonal or paracrine effects through adipokines that lead to atrial fibrosis and cell death and replacement fibrosis. There's a hypothesized, at least in animals, intermyocyte disruption. So there's infiltration of this epicardial adipose tissue into the tissue of the left atrium. Also, there are molecular changes at the level of gap junctions, which play a significant role in impulse propagation and conduction velocity, and isotropic and anisotropic conduction within the atrial tissue. All of this adding up to conduction slowing and changes in the action potential duration, and creating further changes that promote atrial fibrillation and fibrillatory conduction. Now, our work here in this space has been also using and leveraging our expertise in cardiac MRI. And this is work that we've been working on now for the past couple of years. And this is funded through the John Locke Charitable Fund, where we tried to study obesity and body mass index and the association of body obesity with epicardial fat. So we have started imaging epicardial fat as part of our protocol for cardiac imaging for our AFib patients and some non-AFib patients as well. And the way we do that is through a new MRI sequence called MDixon that we have added to our MRI imaging protocol, together with our usual 3D LGE sequence that we have used for years now to characterize atrial fibrosis. And this is what we are seeing so far. And this is on a cohort of 45 patients that continues to grow. When we segment the epicardial fat that we see from the MDixon sequence around the left atrium here shown in blue, we're also collecting that around the entire heart, as you can see here in the yellow colors. We're also obtaining atrial fibrosis through the usual method that I told you about before. What we have seen so far is an association between BMI, or overall body obesity, and the epicardial fat quantified. In addition to that, we've also seen a statistically significant correlation between the left atrial epicardial adipose tissue and the atrial fibrosis quantified with LGE-MRI. Now, as you can see, the correlation is not linear, even though the statistics show an association. The R score is 0.35. So to us, that means that that fat, it may not tell the whole story about fibrosis, but there's a significant association there. Now, the next step that we have taken is to try and look at how does the fat and the fibrosis actually co-localize. So are the areas where the fat is present likely to be superimposable on areas where the fibrosis is present in the atrial wall? And this is a very exciting project that we've been working on. Yaqub Shaheen is a postdoctoral scholar in my lab, as well as Bahari, who was here last year. Kirsten Kwan and Carter Anderson are actually in Pat Boyle's lab, who has been our strong collaborator on the biomedical engineering and image processing side. And this is what we are seeing in terms of that co-localization or association between fat and fibrosis. So in this example that you see on the top left-hand side of the screen, you can see the fat is reconstructed here in yellow, and in the background you see the left atrial 3D model with the fibrotic areas depicted in green. And you can see that there's a fair overlap between where the fat is and where the fibrosis is. On the bottom panel, you can see that the degree of fat overall is less, and the degree of overlap is also not that impressive. So we've studied this in the entire cohort, and we varied a method to basically quantify the association between any point on that left atrial surface and its relationship to the epicardial fat that's reconstructed in the shell around the atrium. So when we compare fibrotic versus non-fibrotic points on the left atrial surface, and we look at their nearest neighbor and how the association between the atrial fat is and how proximal it is, we actually are not seeing that there's a local effect here. So this measure, which is LEFB, to study the distance between the fibrotic areas on the surface of the atrium and the nearest fat neighbor, does not show any significant difference between fibrotic versus non-fibrotic areas. So our conclusion from this work so far is that, yes, statistically there's an association between the two. There doesn't seem to be a lot of overlap in the space. So the impact of fat on fibrosis in the left atrium is probably not mediated through local infiltration of the tissue with fat, but more likely to be related to adipokines or a paracrine effect on the tissue itself. All right, so that's what I was going to tell you about risk factors and fibrosis and our work in that space. Next, I will pivot and talk about the role of fibrosis in rhythm management, and I will tell you about our most recent findings there. So you already know about this work, where we have shown that the degree of fibrosis that we are evaluating pre-ablation is a strong predictor of response to therapy. So patients with advanced fibrosis do not do well when we do catheter ablation. We also can use our MRI technique to actually study the effect of fibrosis, so the effect of ablation on the atrial tissue and the scar that's generated by that. So if you focus your attention on these MRI images here, this is a pre-ablation scan on the left-hand panel. The middle panel is immediately after ablation, where you could see that there's quite a bit of hyperenhancement in that pulmonary vein antral region, a common area for us to target with ablation. And this persists in imaging that's done further down the line. So what this allows us to do is actually study the association of the pre-existing fibrosis, what we sometimes call the God-given fibrosis, with the ablation-induced scarring. So the tissues that the tissue changes that we create by either burning or freezing atrial tissue with our catheters. Now, since it's the same patient and we're imaging at two different time points, we can actually register those two scans together, and we can study the relationship between the pre-existing God-given fibrosis and the ablation-induced one. And if we assume that those areas that we targeted with ablation with more dense scar tissue that is sort of not contributing to that substrate anymore, we can subtract that out and we can see what's left behind, and we can study what's the impact of the remaining fibrosis or the residual fibrosis on the outcome. And our preliminary studies, these are a couple of publications that we did before on DECAAF1 and also our experience in Utah, where we've shown that the higher the residual fibrosis, the poorer the outcome, sort of the more the chance that the AFib will come back after catheter ablation. So what this has led us to do is a randomized clinical trial, and this is DECAAF2. And this is something that was born out of the results of our previous analysis that I just showed you. A multi-center clinical trial where we actually randomized patients to receive pulmonary vein isolation only as the standard of care, or in addition to that, adding more lesions that are aimed at areas where the MRI has identified fibrosis. So fibrosis targeting in addition to pulmonary vein isolation. So DECAAF2 is one of the largest ablation studies. The ones that I showed you earlier, for example, the cryo studies were about 200 to 300 patients each. This was an 843 patient randomized study. They all got baseline MRIs, and they were randomized to pulmonary vein isolation only or pulmonary vein isolation plus fibrosis targeted ablation. All of these patients also had an MRI scan 3 months after their ablation. So this is to characterize the scar that's generated from the ablation and continue to look at this relationship between fibrosis and scarring. The primary endpoint for the study was arrhythmia recurrence. Now, these are our main findings here, and the intention to treat analysis for this randomized prospective trial. Actually, we did not show an improvement in the arrhythmia control when we used this approach of adding fibrosis targeting to our conventional pulmonary vein isolation. So what we can conclude at this point is that fibrosis-guided ablation was not superior, as I just mentioned. And a corollary to that is that fibrosis itself, identified by cardiac MRI, should not be an ablation target, at least using our current ablation technologies. So if we circle back to our patient that we started with earlier in the day, he went on and had his cardiac MRI. This is what his MRI showed, and he scored about 12%, which puts him in an actually favorable category in terms of response. He decided to go on for catheter ablation, which we completed with the cryo balloon here, and he has been doing well. So where do we go from here? Let me tell you a little bit about our current work and future directions that we're taking with this in terms of rhythm management. This is collaborative work that I'm doing with Patrick Boyle from the Biomedical Engineering Department. This is work that he was involved in Johns Hopkins before joining us at the UW in 2018. And this work involves creating computational models and simulations of arrhythmia using our data from fibrosis quantification from cardiac MRI. In addition to the fibrosis that's incorporated into these models, we also incorporate the anatomy of the fibers of muscle in the left atrium. In addition to that, we also incorporate the changes that we know about as far as electrical remodeling within the atrial myocytes that impact primarily conduction velocity through that tissue. So what these models allow us to study is the propagation of electrical impulses that are done in silico on these patients that can be personalized based on the degree and distribution of fibrosis. So on the bottom panel, for example, you could see that we are able to, through simulated pacing in silico, to actually demonstrate that with a certain pattern and burden of atrial fibrosis and changes to conduction velocity, we actually can simulate atrial arrhythmias in silico and study where are the drivers and potentially where our therapeutic targets can be. And this is actually what Patrick's group has done on a small scale in this study, where after identifying where are potential drivers for atrial fibrillation in silico, they performed virtual ablations. So in silico, you can render any tissue refractory basically and create an area of conduction block. So these are the virtually ablated areas in orange. And you can see that when they are applied here at different parts of the atrium that correspond to these reentrant drivers, the model stops being inducible in silico. Now, Patrick and his group have taken that to humans and studied it, like I said, on a small scale, where they actually provided the operators in the EP lab with a design line, basically a personalized approach to where the ablation should land based on these modeling results. And they have shown that this has led to an improvement in the outcome and suppression of atrial fibrillation using this approach. So this is currently being studied with more larger prospective studies that we're all waiting to see. Here at the UW, we also are lucky to have a very large data set of patients who have had their MRI and fibrosis characterized before ablation, as you know, and also after ablation. So we actually know where the lesions landed. And that allows us to study why certain ablations worked and why others didn't, and what's the role of this underlying fibrosis before ablation, and also how does that interact and what type of arrhythmia do the patients recur with? Is it going to be atrial fibrillation or atrial flutter after these ablation lesions are applied? So this is work that our cardiology fellow, Fima Machuret, who hopefully will be our EP fellow, is currently working on. Savannah Bufelko is also a doctoral student in the bioengineering department, supervised by Pat Boyle, and I'm also on her PhD committee. And Pat and Savannah, Fima and Savannah have been working on this. This is work that's also funded by the ITHS collaborative grant that Pat and I got funded for earlier this year. And we're excited to continue this work together in the future. So this is some of Fima's work, where he's also looked at the impact of conduction velocity that's incorporated into these models, and has shown that when the conduction velocity is modulated, as you can see here, when the conduction velocity is lowered, there's more crowding of these isochrones. When the conduction velocity is increased, the conduction is faster and the isochrones are more separated. But what Fima has shown, and this is work that he just presented at the American Heart Association scientific sessions last week, is that this modulation that we can do with our modeling work, we can actually improve the agreement between what our models are showing and what the clinical results are. So we're very excited to continue this this work in the future and apply it more to take care of our patients. So I will stop here as far as the associations and the role of fibrosis with rhythm management, and I will pivot to stroke risk and how do these relationships work out in patients with atrial fibrillation and without atrial fibrillation, namely focusing on patients with embolic stroke of undetermined source. So in patients with AFib, we have demonstrated before that those with a prior history of stroke actually have a higher and more significant degree of fibrosis compared to those without a history of stroke. And this is something that has been proven even in larger studies, bigger cohorts. Patients with the highest degree of fibrosis have a higher cumulative incidence of stroke or TIA compared to the other group. we've went to the source. We've gone to the source of blood clotting and looked at the association between atrial fibrosis and appendage thrombus on TEE examinations. And we've shown that the patients who have thrombi on TEE also have a significant level of fibrosis compared to patients without thrombi. The patients with spontaneous echo contrast kind of live in between those two sides of the spectrum. We've shown that our ability to predict who's going to have a thrombus on TEE improves significantly when the modeling includes the degree of fibrosis. So we improve the area under the curve from about 0.67 using clinical risk factors to 0.8 when we include fibrosis in that as well. Now, we've also looked into the mechanism of this in AFib patients and have shown that for patients with AFib and extensive fibrosis, there's a reduction in the left atrial strain compared to those patients with a lesser degree of fibrosis. And we've also taken an interest in patients without atrial fibrillation, or those patients who have strokes but are not shown to have atrial fibrillation in heart monitoring, both short-term and long-term. And this is our ESUS population, or embolic stroke of undetermined source. And this is a subset of cryptogenic stroke, which accounts for about 30% of all ischemic strokes in the United States. Now, for these cryptogenic strokes, or strokes of undetermined source, AFib is suspected. The brain imaging suggests that these are embolic strokes that have a high likelihood of being cardiac in origin. But after going through a bunch of exclusion criteria and not finding anything to blame the stroke on, these patients are monitored for the presence of atrial fibrillation. And extensive cardiac monitoring in this group has shown that the positivity rate in terms of diagnosing atrial fibrillation is only about 30% after about 3 years of follow-up. And this is not much. So another way to say this is that 70% of these patients actually do not have atrial fibrillation. And there's another set of studies that also used loop monitoring and prolonged cardiac rhythm monitoring in a different stroke population that's also ischemic but not embolic. And there was a similar degree of atrial fibrillation that was found. And the big question remains is how much atrial fibrillation is needed to actually initiate treatment, or should we be looking at this in a totally different way? Another sort of piece of collaborative or supporting evidence comes from our patients with implantable cardiac devices, where we actually can study the degree of arrhythmia burden and also its association, temporal association, with thromboembolic events. And what we have observed in these studies is that there is actually a temporal disassociation between when atrial arrhythmia episodes occur and are picked up by our cardiac rhythm monitors, and where the actual thromboembolic events occur. So that too raises a lot of doubt about the direct link between the arrhythmia itself and thromboembolic events. More evidence to support the role of atrial disease rather than atrial arrhythmia in this are several studies that have looked at patients with stroke and without known atrial fibrillation, but looking at their atrial function, either with strain imaging or emptying fraction, as you can see here by MRI. They have also suggested that the association exists between atrial disease measured by these two parameters and stroke in the absence of atrial fibrillation. So this is all evidence that has led to a change in the paradigm of how we think about atrial fibrillation and stroke. So rather than thinking about cardiovascular risk factors and atrial fibrillation, both required to cause thromboemboli and stroke, we are now thinking of it as cardiovascular risk factors and genetics and other factors leading to an atrial substrate dominated by atrial fibrosis that actually might manifest itself with atrial arrhythmia and atrial fibrillation, but can also have a direct relationship to thromboembolization and stroke without having to go through a arrhythmia phase. So we studied this here, and this is another shout out to the Locke Charitable Trust. This is one of my first Locke Awards that I got when I first got here, where we studied this and enrolled patients with ESUS and compared them to controls without AFib and with AFib, and obtained cardiac MRIs. And this is one example of these patients with ESUS showing extensive fibrosis. But we have shown here that patients with ESUS have a significantly higher atrial fibrosis burden compared to controls. And it's very comparable to what we observed in our AFib patients. We've gone on to study this patient population more extensively. We've recruited a couple of other centers and enrolled more patients, both with embolic stroke of undetermined source and also with other kinds of stroke like a lacunar stroke, and also patients with AFib and stroke, and compared their fibrosis burdens. So this is work that I presented in the late-breaking clinical trial session last year at the Heart Rhythm Society, and is now published in the European Journal of Neurology earlier this year, where we showed that, again, these ESUS patients are very similar to their AFib counterparts in terms of their fibrosis burden, but significantly more diseased in terms of comparisons to lacunar stroke, where it's not known to be an embolic mechanism, and also to the control group, which has neither AFib nor prior stroke. Now, for this ESUS group, we also followed them prospectively, and we wanted to see whether the degree of fibrosis actually predicted who's going to have recurrence of their stroke, which will have significant implications in secondary prevention measures, and also new onset atrial fibrillation, another ground for actually treating those patients in terms of starting oral anticoagulation. So we did pick up 6 recurrent strokes and 5 newly diagnosed atrial fibrillations in follow-up. And when we grouped the patients with ESUS into 2 different fibrosis groups, greater than 12% and less than 12%, and this is based on a dichotomy that we saw in that Carmen Tandon paper that I showed you before. What we show here is that the likelihood of either recurrent stroke or new onset atrial fibrillation was 4 times higher in that higher fibrosis group. And these are the Kaplan-Meier curves showing early separation and continued separation of these 2 endpoints in that group in prospective follow-up. So where do we go from here? And I know that we're going into the last 10 minutes of the talk here, and I do want to leave time for questions. These are ongoing research efforts that we're doing in this space. So this is a paper that we published earlier this year, where we took this question to, again, the computational modeling lab. This is work done by Savannah Bifulco, where we did some computational modeling on those patients with ESUS. And we wanted to try and understand, if they have this much fibrosis, why don't they have atrial fibrillation? And we did these simulation studies in a cohort of 45 ESUS patients and 45 AFib patients. And what we found is that the inducibility in silico was very similar between the 2. And that the higher the degree of fibrosis, the higher the likelihood that the model was going to show inducible arrhythmia. The question remains, why do those ESUS patients not show atrial fibrillation? And our answer at this point, our hypothesis, is that they may just need to be triggered into it. So maybe the stars have not aligned yet for the proper trigger at the right time in that atrium to actually manifest with atrial fibrillation. But regardless, those patients, because they have an underlying disease substrate, they have already manifested with the stroke outcome. Now, Another area that we're taking this is studying the electromechanical association of fibrosis. So what I'm showing you here are two models that we constructed from the same patient, one with out fibrosis, as you see it on the left here, and one with fibrosis on the right. So as we impose fibrosis in our electromechanical modeling, and this is work that we are doing in collaboration with the Medical University of Graz in Austria, with Gernot Planck and Christoph Augustin, who are helping us with this electromechanical modeling using fibrosis. What we show here is that when fibrosis is incorporated into this electromechanical modeling, that the volume of blood that is ejected out of the left atrium is significantly lower when the degree of fibrosis is higher. So again, speaking to that effect of fibrosis on the mechanical function of the atrium and the contribution of that and helping us understand stroke and stroke risk. Another important factor that we are studying in this pathophysiology of thrombus and stroke in these patients is fluid dynamics within the left atrium and the flow of blood in and out of the left atrial appendage, where we're interested in residence time in the left atrial appendage, with the basic premise being here that the higher the residence time, the more likely that a clot will form. And we are doing this collaborative work with Juan Carlos del Alamo from the Department of Mechanical Engineering here at the UW. And we're studying the fluid dynamics of blood flow in and out of the left atrial appendage in conjunction with the electromechanics that I showed you earlier with Pat's lab, as well as Christoph and Gernot from Graz. So my last slide here before I give my thank yous is our future direction. So this here is my atrium, and as you can see, I do have some fibrosis, and I want to know, what does it mean? So am I going to have AFib in the future? Am I going to have a stroke? What should I do about it? And we're trying to understand specifically that in using our computational work and our mechanistic questions, and trying to understand the role of these changes in who's going to develop AFib, how to manage atrial fib, and also who's going to develop a thrombus and who's not going to develop a thrombus, who doesn't need to be on a blood thinner, who needs an ablation procedure and who doesn't, who needs a left atrial appendage occlusion and who doesn't. So this whole conceptual model, we put our thoughts together on and published it in Heart also earlier this year. And thank you for allowing us to share this with the readership of Heart. Dr. Otto gave us this opportunity. And I'm happy to say that this work and the proposed mechanistic work that we are working on has received a very good score on our R01 submission, and hopefully we'll be able to continue this work early in the next year, funded through that mechanism through NIH. So I would like to recognize all of the collaborators that I've worked with over the years here and elsewhere in the AFib program on the clinical side. Also the volunteers and the postdoctoral or scholars that have been working with me on the fibrosis imaging and clinical applications. I'd like to recognize Graham and Brenda Siddall for their support. Pat Boyle and Juan Carlos del Alamo are my main collaborators here on campus. Also in Europe, Gernot and Christian Mankoff in Germany, and many others that I probably failed to put on this thank you slide. And the work continues. So I will stop here and I will take your questions. Thank you very much for your attention.
Well, thanks so much, Nazem. That was really excellent. It looks like we have a few in the Q&A. Do you want to handle those? Can you pull those up, or do you want me to do that for you?
Sure. Yeah, I just opened the Q&A. regarding the study that looked at the impact of weight loss, what percentage of patients were able to actually achieve sustained weight loss? Did it suggest any factor, demographics or otherwise, that might make the weight loss intervention more likely to be successful? That's a great question. So one of the biggest problems with trying to reproduce these Australian data is compliance. And lots of centers, including ours here at the UW, have tried to implement a program to help patients lose weight. The way they did it in Australia was very aggressive. They actually were very prescriptive in how they wanted their patients to lose weight. They told them what to eat. They actually gave them the food that they wanted them to eat. And even with that, about a third of them achieved that goal. Another third maintained the weight, didn't gain, but didn't lose. And then another third continued to gain weight. So it's a big problem and it's a difficult goal to achieve. And one of the avenues that we're actually considering is specifically for this obese category of patients, whether interventions like gastric bypass or the many variations on it would actually lead to changes in the fibrosis or any of the other measures that we're talking about. Nina, what are your thoughts on using echo left atrial strain as an alternative to MRI to use in prediction models post-cardioversion and ablation? I think that's a fantastic idea. I'm happy to collaborate with you on that. I think we have a great opportunity to do that in our labs, both here at Northwest or wherever you want to do it. Harborview also, I think Gary's very interested in that as well. Alex Taylor, do you offer cardiac MRI for atrial fibrosis assessment to patients with low CHAD scores to inform decision-making about anticoagulation? Great question. We're not there yet, but it's a very, very interesting thought. We are gearing up to do a prospective clinical study, but it's on patients with actually higher risk, where we are focusing on ESUS patients. So they've already had a stroke and we want to quantify their fibrosis and randomize them to receive anticoagulation or not based on the degree of atrial disease. But taking it to AFib patients with low CHADS VASC score would be another very clinically important question to answer, and certainly something that we can explore with you if you're interested. All right, Chris Longenecker, is left ventricular extracellular volume fraction associated with AF? Is it possible to measure left atrial extracellular volume fraction? The answer is yes for the ventricular side. And is it possible to measure left atrial extracellular volume fraction? It's hard, but, and we haven't tried it, but we can definitely explore that as well. We have strong collaborations and we built a lot of bridges with our radiology department. The issue has been that our scans are already on the longer side. So if this is going to involve any additional time in the scanner, we better start it more on the research side of things and go from there. Dr. Poole, can you comment on the potential for fibrosis reversal? Yeah, that's a very fascinating question. For the longest time, didn't think that that was even possible. However, there's some very interesting data, mostly from Australia again, not human data, but sheep data, where Prash Sanders and his group have overfed their sheep and caused them to be obese and sacrificed them and demonstrated that there's a lot of fibrosis associated with that obesity. And there's another group that actually were then, after overfeeding, were reversed back to a normal feeding diet, and they've lost the weight and gone back to normal. And when those sheep were sacrificed, there was actually less fibrosis. So I would say it's very intriguing. I have yet to see it in other circumstances or other scenarios, have not seen it in an MRI way of assessing fibrosis, but it's definitely something that is worth exploring.
That's great. We're at 8:30, so that was a perfect timing there. Thank you so much, Nazem. That was really fabulous today. And thanks to everyone who showed up today.
Thanks for the opportunity. Have a great day, everybody.